Hello, and thanks for joining us today. I'm Dr. Lisa Alvitro, and I'm joined today by Leanne Jones, a member of my clinical staff. And we'll be talking about the Forsus appliance, the Class 2 correctors, and this seminar was really targeted for the orthodontic staff in maximizing treatment efficiency. We've done similar webinars on the appliance and different uses, and to me it's really important that the staff, and not only the clinical staff but the entire team, understand the appliance, what it can do, how exciting it is, and also the ease of use for not only the patient but for the entire team as well. So we'll talk about some of the basics, and then Leanne will really share her experience and some of the clinical situations that she may be running into as a technician. And we'd like to welcome all of you. The exciting thing for us is we get to share information with people throughout the world this way. So we want to welcome everyone and look forward to the time we have to spend together. Many of you realize, why you like to use a Forsus, and please, make sure that everyone in your office understands as well. It's really effective, and when you start to use it, there's just so many fun things that you can do with the appliance, and the ease of insertion. Your staff will really appreciate that there's no lab procedure. Your patients appreciate that too, because it's not an extra step. There aren't extra appointments. It's a very easy technique that's quick to master. And I think one of the things that I like to share is, it is independent of patient compliance. And we don't refer to it as a non-compliance appliance, but we do like to say that it is independent. That sounds much more positive, but it makes things really predictable for us and has changed the way that we can practice. I can relate to patients, my staff can relate to patients, and really enjoy watching their progress. What is the Forsus appliance? And obviously many of you know this, but it is considered a fixed Class 2 correction appliance. So you're going to see some similar treatment effects to other fixed Class 2 correction appliances, but I think some of the advantages are the efficiency and the predictability, and also, like we've talked about before, that you can vary the force vectors, how you attach it. Your staff will start to understand that as well, that some Class 2 patients need more vertical control, some need more horizontal force, and they'll be able to see that and how it works in their patients. And there's also some multiple applications for the appliance as well. Often people will think of it as just a substitute for Class 2 elastics, but it's actually much more than that, and that's something that's really important for your staff to understand as well. As we've talked about before, we use it for Class 2 correction in both deep and open bites. It's a great distalization appliance when you're looking to increase arch length, and using it for anchorage in the maxilla for extraction cases, and also anchorage or controlling mandibular incisor position, that early intervention in severe Class 2 cases, and then also for maxillary mandibular asymmetries. And I encourage doctors too to make sure that your staff understands when you're using it for different things, because maybe your wire selection or how you have the appliance installed is different for each one of these. And if they understand that, boy, it is more than just a Class 2 correction or a substitute for elastics, they'll start to understand why you're doing it differently. And I encourage even doctors to share some of the past webinars with their staff and go through them so they understand the difference. That staff training is so important, and I think part of it is not only does your staff need to know, but they need to be able to educate patients and parents. I like to think I'm a pretty believable person, but my staff maybe has even more credibility. Patients and parents really tend to look to them. After I say something and I walk away, I hear the same question being answered. And I really want my staff to be comfortable knowing the answers and confident as well. And they're going to be able to really support that patient and help them get excited about it. Often, again, I think I'm approachable. My patients are more open to maybe share their concerns, or, what is this going to do, or I'm having problems with the appliance. They're going to be more open to share that with staff. And, a lot of times when we think about staff training, we tend to focus on the clinical staff. But make sure your front desk, your administrative staff, everybody understands a little bit about the appliance so they can encourage people as well. Because, I think preparing the patient for getting used to their forces is really, really important. That everything that you tell someone before is information. You may say the same thing afterward, but then it kind of sounds like an excuse. So upfront information is really valuable, and we'll talk about that. For us, giving the patients and parents goals to look for throughout treatment can be very exciting for them. We like to take pictures the day we're placing the appliance, point out the overjet. We'll also take a cephalometric film at that point so they can see really, their entire structure, the maxilla, the mandible, the teeth, where things are at, and show them, okay, this is how much your overbite's going to go away. This is what you can look for. And it's really powerful too if you have some similar cases. So, create a library so that when you have someone that has maybe really procumbent maxillary incisors, your case can, your staff, or you can pull up a case and say, boy, this young man looked like you then. Look at what he looks like now. That's what you're going to be like. And it's encouraging for them so they see what's going to be at the end result. And that's part of that first step, is creating the excitement. And I can be excited about it, but if my staff is like, oh, I don't like this appliance, or you're not going to like this appliance, so it's awful, it's going to affect the parent and the patient as well. And I think if you have staff that are maybe dreading it or aren't familiar, it's because they're unfamiliar with it. Once they see what it can do and how much fun it can be to see these changes, they're going to get excited too. Because I think everybody in your office wants, what's best for these kids and for your patients. And when they see that they can predict this is what's going to happen, they gain credibility with their patients too. For me, I love the way that it's removed the negative conversations from my day, and my staff has loved that too, because often they were the ones who had to initiate that negative conversation, like, you're not wearing your elastics, are you? Or the kid who said, oh, yes, I am, and you're looking at thinking, wow, you look the same as you did last time. So it's going to remove those negative conversations and let them enjoy their patients as much as you do. Now, here's just a fun example that we use out of our library, that when you look at a nice, handsome young man now that he's 18, 19 years old, and you look at what he looked like before his forces, that's exciting for staff and for also patients that may look similar, that they see what is in their future. So just create a simple library. Obviously, we let patients know that they're part of our library, and they're very excited to share as well. Sometimes we'll even have patients offer, if anyone needs help getting used to the appliance, let me know. I can talk to them and show them what happened for me. So after you create the excitement in the staff and in the entire office, you really have to go now to the clinical part, the mechanics of it, how to work with it in the clinic, how to solve problems so that if patients are experiencing any difficulties, they know the solution. And it's very powerful that they know the answers to patients' and parents' questions and not have to say, well, let me ask the doctor. Anyone in the office should be able to answer questions regarding the appliance. And your clinical staff should really be able to answer clinical questions as well. I think the important part, too, for the forces and training is scripting. Everybody has to have the same message. For us, scripting simply means writing down questions people ask about it and what is the answer. How am I going to talk about the appliance? And when I present it at the initial treatment plan and my treatment coordinators are with me, we talk about the automatic correction. We talk about the stress, the ease of use, how it's so easy compared to other methods. I'm sorry. Durability, that's important. I always start at that first conversation about it's durable. It's not indestructible. There are certain patients, if they are hard on appliances, if they don't do what they're supposed to, they may break the appliance. And again, we never refer to it as non-compliant appliance, or we use this in patients who don't do what they're supposed to. And the simple way that I like to describe this, and it's a scripting that we use through the office, and I think it's very, it works out really nicely, is when I'm describing treatment in the initial consultation, I always will show the patient braces, and I'll say, okay, your braces are going to line up your teeth in the top and bottom jaws. Your springs will fix your bite, so your top and bottom jaws will fit together. And then you get your braces off. And we repeat this. Your braces line up your teeth, your springs fix your bite, you get your braces off. 3 simple steps. So it's kind of comical because patients will start asking for their springs. And some people will think, well, that's hard to believe. But they know that's the next step. I got to get my springs, and then I get my braces off. So if everyone keeps reinforcing that, it really helps patient understand what's happening. So I'm going to turn things over to Leanne, and she's going to talk to the staff, and obviously there's doctors on the line as well. What are some of the basic components of the appliance?
Okay, again, I would just like to thank everyone for joining us today to listen to the lecture, and I hope that I can share some knowledge that I've gained throughout my experience with the Forsus appliance with you. And I will do my best to speak slowly, so I hope everyone can understand me clearly. Again, like Dr. Alcatraz mentioned, I'm going to start by talking about the basic components of a Forsus appliance. And you can see from the images here, really are not that many components. It's pretty simple to use. It starts with the upper and lower arch wires that you'll need, which vary, I guess, depending on your bracket slot size or prescription. We typically use a 19 by 25 beta titanium lower arch, which is rigid enough to support the Forsus. And then also the molar band with the headgear tube where the Forsus appliance will attach. And your spring modules, which could be attached with either an L-pin or the Easy module, and the Forsus rods in varying sizes, and the split crimps that can be used to activate the Forsus. The basic steps for placing a Forsus appliance are placing the mandibular arch wire and cinching it distal to the terminal molar. We like to do the appointment prior to placing the Forsus to increase patient comfort. I'll talk more about that later. Before placing either the spring or the rod, you'll need to measure to determine which size rod you'll want to place. There's a ruler enclosed in the Forsus kit that you use to measure for that. You place the Forsus spring module into the maxillary headgear tube and secure it either by turning the L-pin or clipping the Easy module. And then finally inserting the mandibular rod, and after determining it is the proper size, securing it to the wire. The biggest challenges in inserting a Forsus appliance really actually are not that big once you're comfortable with it. Initially in our use of the appliance, we found that placing the L-pin could be difficult. They're really a bit longer than they need to be, and it can be difficult to get the full length of the pin distal to the headgear tube. So now, before placing the Forsus, we actually trim a few millimeters of the L-pin so that it's easier to get into the molar tube. We actually pre-trim all the L-pins now so that they're the proper length in the Forsus kit, and it makes it easier for us when we're placing them chairside. You can see here the L-pin is turned up and over the headgear tube to keep it away from the occlusion and away from the cheek. If you turn it more in line with the headgear tube, it can irritate the cheek tissue more, and I've seen sometimes people tucking the L-pin behind the little auxiliary hook, thinking that'll keep it more secure, but it can cause irritation then of the gingiva. So just up and over the headgear tube is really the easiest and best way to keep it from irritating your patient, and also making sure it securely holds your Forsus. The angle of insertion is one of the challenges when first using the Easy module. If you try to just push it directly straight back into the headgear tube, it can be kind of a snug fit. It can be difficult to get the clip to really latch into the headgear tube. So if you kind of angle down to open the Easy module a bit, then slide back, it goes right into the headgear tube, and you can actually feel a bit of a click as the clip seats at the distal of the band. Easy 2 modules are designed to be used with 3M Unitech occlusal headgear tubes. It's very, very important that you do this. I've answered questions from several people wanting to know why the Easy 2 module pops out frequently, only to find out that they're using a different molar band. The headgear tube size, length, offset from the wire slot, and the contour are factors that are important for proper fit. The two are designed to be used together and work well, and you shouldn't see disengagement of the Easy module when you're using it with the molar band it was designed to go with. Again, the biggest challenge in removing a Forsus appliance is really not a big challenge at all. I know when we first were removing Forsus appliances, you would be advised to kind of cantilever the rod off of the wire, which was very difficult and would sometimes break brackets and things like that. We've found that using a pin and ligature cutter to open this compressed loop is the easiest way to do it. It's very, very simple. If you place the beaks between the ends of the Forsus rod and just squeeze them gently, the U-joint will open and you can remove the rod easily. You can see an even better picture here. You have the flat side of the pin and ligature cutter against the longer portion of the rod, and when you squeeze, it pops that bend right open and you can slip the rod off. Removing an Easy module is, I think, another thing that once you're comfortable with is very, very easy to do. If you pull down slightly on the distal portion of the Easy module, it disengages the clip, and then you can slide right out of that headgear tube. Removing an L-pin can be tricky just because, if you get a bit of a bend in it, it can be hard to slide out of the headgear tube. But if you keep the rod and spring engaged with the patient closed versus disengaging the spring and rod and having them open, it comes out much easier. You can use a Weingart plier to just uncurl the pin, and the active spring will push the pin out distally, and then once the majority of the pin is out of the headgear tube, if there's just a slight bend left, you can kind of use the plier to curl in the posterior, and that slightly bent area will slip right out of the headgear tube. When are patients ready for Forsus placement? This can be an important thing for staff because you want to be able to be prepared at the beginning of a visit with all the things that you'll need to place the Forsus. In our case, it's easy to know because not only are the maxillary and mandibular arches coordinated in the transverse width, the rigid mandibular arch wire has been placed and cinched the visit prior. So these are the two things that you want to be sure you've done prior to placing the Forsus. Whether you do it at the same visit or a visit prior is up to you. If you see a space in the mandibular arch, there can be a couple of reasons for that. You may not be cinching your wires closely enough. It can be maybe difficult if you're not really familiar with the appliance to tell how close is close enough. Also, the appliance could be overactivated. If you look at the two pictures of a cinched wire, this one looks as though it would be close enough. That very small space between the wire end and the the molar tube is enough that you can see a space of that size, maybe a couple of millimeters open in the lower arch. If it's cinched as flush as possible and completely against that molar tube, you'll be much more in control of your incisor movement and you won't see the spacing. Cinching the distal ends of the arch wire that closely is actually really easy if you use this technique. We begin by using a gerback plier to start the bend in the wire, and then once you've got just a bit of a bend started, you can use the tip of the plier in the wing of the bracket on the molar band and kind of cantilever the wire against the wings, and then you'll have it cinched completely flush with no space between the wire and the slot. What does the correct activation of a Forsus look like? There are many ways to tell. You can just look at the space between the compressed spring and the stop on the rod. With the patient biting in centric occlusion or centric relation, you should see about 2 millimeters of space between those two, between the compressed spring and the stop on the rod. I have some pictures later too that will show other signs of overactivation in the appliance. When checking your activation at the placement of Forsus, it's best to check prior to crimping the rod. We showed you the really easy way to remove it, but you don't want to do that over and over again. So after you've measured and you've selected the rod size you think you want, we always place the rod on the wire and have the patient close completely and then check again that activation to make sure that it is proper before the rod is crimped into place. Overactivation of the appliance can cause debonding of brackets, unwanted movements, flaring of the lower incisors, and also rotation and rolling of the maxillary molars. So these are things that you may encounter. We've got some pictures to show so you can recognize that, but very often is due to overactivation. These are some of those pictures I was mentioning that show you the very visible difference in correct activation and overactivation with the Forsus. In the picture on the left, you can see that the spring and the rod lay nicely flush with the dentition. You can see that the spring is not fully compressed. If you look at the picture on the right, you can see how the rod starts to roll buccally and also how the spring module is completely compressed. No space visible between those little rungs there. With an easy clip correct activation, it looks very similar. You can see how the rod lays nicely with the dentition, no rolling. Here in the picture on the right, you can see that it does roll out, which not only is going to possibly cause the brackets debonding and unwanted movements, but also more cheek irritation for your patient. Overactivation of the appliance also results in the tube being pushed beyond the end of the spring, so you can see that as well if you're looking for it. Just another little visual cue to maybe remind you to double check your activation. In a correctly activated appliance, you can see again the spring is not fully compressed and there's no tube visible beyond the end of the spring. When will my patient's Forsus need reactivation? Yet another thing that's great for staff to recognize so you can be prepared and have the needed items for that activation. At each appointment after the Forsus has been placed, we'll check the existing activation. Typically, only one split crimp per appointment will be needed, and you can also activate the appliance unilaterally, for midline discrepancy or something like that. To check the activation, have the patient bite in centric occlusion or relationship and hold the rod so that it's steady and completely compress the spring. The activation you need will depend on the amount of rod visible between the stop and the spring. Again, in a correctly activated appliance, that's about 2 millimeters. So if you're seeing much more than 2 millimeters visible, you'll know that it's due for activation. 2 millimeter crimpable stop is the typical amount of activation. Again, that can be done unilaterally. Our appointment intervals are about 6 to 8 weeks, and typically we'll use one crimpable stop at each appointment. Exceptions for that would be in non-growing patients, maybe a bit of a longer interval, 10 to 12 weeks, to allow for the movement that you want. After 2 activations with a split crimp, a new rod is needed, as the rod length will become too short and it will tend to disengage from the spring module. Instead of using more split crimps, you'll need to increase the rod size by 2 to make up for the 2 millimeters that you've, 4 millimeters that you've activated previously. And this is a picture of a 25 millimeter rod being reactivated with a split crimp. You can see here where we've checked, there's space visible. We know we want to activate it. You take the single split crimp and with a Winegard plier, place it around the rod, distal to the stop, and squeeze it in place. And then you can see in the final picture here how that has increased the activation by 2 millimeters. How do I activate a 22 millimeter rod? It is possible and really convenient, because sometimes you're just not ready for that 25 millimeter rod. So what we found is that you take a single split crimp and place it at the U bend here and either tack weld it in place or secure it with even a pin and ligature cutter, as long as you know that it's secure. You can then place a second split crimp behind that. The first one will act as a stop. The second will bump into that and activate the appliance by 2 millimeters. And you can imagine then the rod, or rather the spring, would be stopping here versus going all the way to the bend in the Forsus rod. What if my patient overcorrects? It's very important for staff to know that these things can happen, and that it's something that's easily corrected and nothing to be concerned about, so that you don't have a look of shock that might make your patient uncomfortable. This is a patient who overcorrected, of course. So at that appointment, the Forsus was removed, and you can see where there's a bit of torque loss here. We didn't want to distalize the molars, so the upper arch is chained 6 to 6. So when we removed the Forsus appliance, we removed the chain from molar to molar to increase the torque on the maxillary incisors. You can also increase the maxillary arch wire size, depending on what you have placed. The lower arch then you can chain molar to close any space that may have developed, and it will also allow the mandibular incisors to rebound. And then we would prescribe the patient to wear Class 2 elastics or Class 2 box elastics. And this is that same patient, 4 weeks after Forsus removal. She's been wearing Class 3 elastics just at night. You can see again the torque in the upper incisors is more ideal. You can see the same for the lower incisors. And then just another 4 weeks after that, looks fantastic. So something that might have been unnerving to a staff member is easily corrected and nothing to be worried about. So there you go. You can see again, just 8 weeks different in those 2 photos. What if my maxillary molars intrude? That's another thing I think that can be a little scary if it's the first time you're seeing it as an assistant and you see maybe a couple of millimeters of intrusion. When that happens, after the Forsus removal, it's nothing that would require you to remove the Forsus early, anything like that. After the Forsus removal, we place a nine-tie wire. The first molar will rebound right away. You can see the difference in these 2 pictures. And again, those are just an appointment interval apart, so within just that short visit, the first molar has rebounded. How do I decide what size rod to use? It depends based on the rod location that you're going to be using. There are multiple options for that. The initial manufacturer's design was to place that rod distal to the cuspid bracket. You can also use an omega loop in your arch wire, which gives you more varied angulations, and it keeps the rod from contacting the brackets. But we prefer to use the first bicuspid placement. You can see pictures here, the cuspid, omega loop, first bicuspid, and also a crimpable hook option should your patient break a bracket mid-Forsus treatment. When measuring to determine your rod size, you use the included ruler in your Forsus kit. there's a little lip on the ruler that you want to place against the distal of the headgear tube and measure to the distal of the bracket where the rod will be located. It's very important when you're measuring to make sure your patient is biting in centric occlusion or centric relation and not in a protruded position to get an accurate measurement. The number that is at the distal edge of the bracket is the rod size used to achieve the correct activation. It's not uncommon for us to hear that somebody has measured for their forceps. They see that if they want to place it at the distal of the bicuspid, it says 22. That's what size fits, so I must go one size larger for it to be active. The activation is included in that measurement, so there's no need to account for it yourself. And if it's kind of close, it's best to go with the smaller rod size to avoid over-activating the appliance and again causing debonding of the brackets or unwanted dental movement. You can see in this picture then, based on that criteria, that the ideal rod size, should you place it at the distal of the first bicuspid, would be a 22 millimeter rod. Here's a picture of that bicuspid hookup that we routinely use. Typically, when placing distal to that first bicuspid, you're going to be using a 22 or a 25 millimeter rod. How do I level the occlusal plane after forceps removal? Once the forceps is removed, you'll place a flexible wire in the mandibular arch because, of course, you've got that rigid wire in during forceps treatment. You want to allow those teeth to extrude. Keep a maxillary rigid arch wire in to resist extrusion in the upper arch, and then just have the patient wear box elastics. You can see in this picture, this is the day of forceps removal. We've gotten the class 2 correction but need some settling. We prescribed the patient to wear box elastics, and 8 weeks later, this is the settling that you see. And that's just a flexible lower NiTi wire. What if my patient loses a mandibular first bicuspid bracket? It's not a frequent thing, but it does sometimes happen in our office, and we would think maybe early when in our experience with the appliance that you need to remove the forceps or rebond the bracket or something like that that would really slow your treatment progress, that you can actually use a strong crimpable hook to place on the arch wire to use as a stop to hold the rod. So you can see in the picture here that's just crimped securely in place. Leave the bracket off and you can continue your class 2 correction. There is a picture here of the hooks we prefer. Those are the gripper hook series from Ortho Specialties. They do work really well and they're very easy to crimp into place. They're a bit larger also than a lot of crimpable hooks, which makes them more ideal for using as a stop. Can you use forceps while waiting for eruption? Most definitely. You can see in the pictures here that you can use a little open coil in the lower arch to maintain space for, say, erupting cuspids. You can still place that forceps distal to the first bicuspid and start your class 2 correction while you're waiting for those to erupt. Same thing in the upper arch. You can also, since it is excuse me, a distalization appliance, you can create space for teeth for, say, blocked out cuspids also. What if my patient is biting the spring module, or what if I hear a clicking sound? This is something you may encounter as a staff member. Maybe the doctor's even placed the forceps, everything looks good, your patient sits up, and then you hear the clicking sound. What can you do? It's likely because the spring is lying too close to the dentition. You can see here how the patient would be biting against that spring module. That would cause your clicking sound, and they may say that it's difficult to bite down. Causes for that can be a maxillary transverse deficiency that's keeping that upper portion of the spring module too close, or possibly a rotated molar. And what you can do to correct that, if you're using an L-pin attachment, is just bend that L-pin buccally, and that will change the angulation of the spring module so that it is not interfering with the patient's occlusion. And there's another picture that shows the patient now not biting on the spring module. why did my patient break the tube off of the molar band? Again, this can be potentially due to inadequate transverse width or overactivation of the system. You can see here, this is a good picture, I think, of the maxillary transverse deficiency. If you look at the two sides, on the right here you can see that the spring and the easy module are kind of laying at the same angle. And then here on the left side, you can see where they're kind of cross one another, which causes the spring to rotate to the buccal, and it binds and puts a lot of force on the headgear tube. So, of course, wherever the point of least resistance is what's going to suffer the damage. Often it's the weld of the headgear tube to the molar band. Again, you can see that that would cause the spring to rotate horizontally as the patient closes, which can also increase cheek irritation too. Another solution, if it's obviously not due to maxillary transverse deficiency, would be to decrease your activation. Make sure you've measured properly with the patient biting in centric relation or centric occlusion, and use a smaller size rod then if you've overestimated. Or you can increase the transverse width prior to placement if you see that that's going to be an issue. With an easy module, you don't have the option of adjusting the attachment pin to the buccal, so you could always remove that easy module and replace it with an L pin attachment. You can see here this picture, the molar tube hasn't been broken, but it has caused some rolling of the molar. Either one of those things could be something you would see due to that overactivation or transverse deficiency.
Actually, I'm going to go back because this picture is so important because we get so many questions on this. You know, as a staff member, if you really look in, Forsus should lay flat with it, particularly if you're at the first bicuspid. It should lay in line with the dentition, and the spring and the attachment should be going in the same direction. If you look in and you see this part rolling out or the crisscross of those two lines, you know something's wrong. And that's either you can kind of troubleshoot yourself or get the doctor to come back, because this type of arrangement is where you start to run into the odd effects, like the band, you know, this whole weld coming off, or the molars rolling out, or it irritates someone's cheek. So, you know, there's a lot of visual things that you can see just when you look in. It should look like this. It should look like a spring. If they crisscross, once you see that in someone's mouth, you can understand how that's just not going to quite work out. So if you visually see that, you know, check that activation. Make sure the patient wasn't protruding when you were measuring. Look and see, is the top wide enough? Or maybe even that molar is rotated in an unusual position. But if you see this, you got to do something about it, because if you leave it like that, you're going to see all those things that Leanne was trying to describe for you. And, oh, I'm saying try. They described. She did a good job. So, okay, I'm going to give this back to you now. Thanks.
Thank you. And Kirsten. Okay, there we go. I think we were kind of right at this area here. What would cause the patient's molar to roll buccally? Again, the same things we were just describing. Make sure you check the activation and reduce until the easy module and spring are in the same direction, unless you've determined it's due to that transverse deficiency or rotated molar. If you see a spring that no longer extends and compresses, it's likely because the interior telescoping mechanism of the spring was distorted. This can happen if the spring and rod become disengaged while a patient is chewing, for example, and they bite that spring module. You can compress the telescoping mechanism, and then the spring is no longer usable. When those two pieces aren't able to slide and function properly, you must replace the spring module. How can we help our patients to adapt to their new appliances? A thing that I mentioned earlier is placing the lower Forsus wire at the appointment prior to placing the Forsus appliance itself. When we place a new, heavier, rigid wire, it's not uncommon for that to, of course, cause a little soreness that then the patient associates with their Forsus. So if we place that wire a visit prior, they've had a chance to deal with any discomfort then associated with that. And it also makes the spring placement appointment very, very quick. It's actually faster for me now to place the Forsus and describe its care than it can be to start class 2 elastics for a patient, having them take them in and out to make sure that they're working properly or placing them properly can definitely take longer than placing a Forsus even. It's important to give your patient realistic expectations, especially for the first 48 hours. With any appliance, just when your patient gets braces, there's a bit of discomfort. It's not uncommon to feel maybe even a little overwhelmed if they're not prepared well. So let them know that the first 48 hours can be awkward, but that they will get more comfortable, and any mild irritation should go away quickly. Also, if your patient really understands what the appliance is doing for them, and you give them goals to look for in movement, it can be inspiring to them, and I think they're less likely to think about minor discomfort when they know that this is really going to be making a change, not only in their bite, but very often in their physical appearance and making them feel better about themselves. It kind of detracts from any minor irritations. We give all of our patients a care kit when they get their Forsus, which includes an additional toothbrush and proxy brush, and let them know that they can brush the springs. They should, to keep them clean. Their brushes may wear out, and to let us know, and we'll give them more. We also include an additional package of wax along with brace relief, which is a topical anesthetic antiseptic gel, and that is fantastic for helping with just minor irritation due to the springs maybe rubbing the cheeks initially. They can dab that on those sore spots until they get used to the appliance and feel more comfortable. We also give a little package of cotton rolls and elastics, which they can use if they should notice the springs disengaging and not being able to get them back together, which I'll show you more about in just a minute. This paper is 3M supplied. You can get these and just give them directly to your patient. It gives them some tips to be aware of as they're getting used to the appliance, and reminds them that it's very important to keep their regular appointments to monitor progress. And they work well. We did decide to make our own custom paper for patients, so it lets them know that it will take some time for them to get used to the appliance, and taking Tylenol or Advil as needed will help, but that they can call the office if their discomfort continues beyond several days. What can your patients do if the springs disengage? On that same paper, we have a nice little diagram here of a disengaged spring, and also how to put it back together. We advise the patients that as their jaws fit together better, it is possible for the springs to become disengaged, and if they notice this happening with any frequency, to call the office so that we can get them in sooner. But we also show them how to kind of rig the spring until they can get to us should they not be able to re-engage it. The package you saw that had the elastics and cotton rolls is just for that purpose. We show the patients how they can use an elastic to wrap around the spring and then around a bracket hook, and it'll keep it out of the way so that they can chew and function if it's going to be a day or so before they can get a hold of us. Will Forsus irritate my patient's cheeks, and what can be done to remedy this irritation? Minor irritation is normal. We've found that inserting the mandibular rod distal to the first bicuspid instead of the cuspid really decreases that irritation. You can see here in the picture the difference in the position of the Forsus springs at the first bicuspid versus the cuspid. And then there's a picture coming up in just a second that I think describes it even better. When you look from an overhead angle, you can see that placement at the first bicuspid really keeps it more flush with the dentition, whereas placing it here at the cuspid allows that rod to kind of stick out from the dentition, where the arch is rounded, and can cause a lot more irritation to patients. There are times when you have to place the rod distal to the cuspid. If the class 2 is too severe, at a bicuspid placement would be too vertical. And if you see this irritation, then as soon as you can move that rod to a smaller size, distal to the first bicuspid, and eliminate the irritation that can sometimes go with that. Kids really like the first bicuspid installation because it's not visible. Both these kids are wearing Forsus right now. You can't see it at all. They're smiling. They can go to school and talk and smile, and their cheeks hide the Forsus appliance. You can't even see it the way that their friends can see elastics in other kids' mouths. Patients can definitely wear a mouthguard with Forsus. This is a concern sometimes of patients, more of parents. They don't want them to have a Forsus during football season or etc., which can delay your treatment progress. It is possible, though, to wear a mouthguard with Forsus, and we've found these great mouthguards from Total Guard, which are designed to fit around the springs. Previously, we were modifying our own. It takes a lot of time. These are great and eliminates that. You do have to call the company directly. They have a website, but you cannot find these mouthguards on the website. So this is the number if you need to get Forsus mouthguards. How do I explain how Forsus works compared to elastics to my patient? Dr. Alvitro kind of reviewed this earlier, but we explained to them that elastics are used to correct tooth position when correcting a bite, and the Forsus is used when we need to correct a bite and reposition the jaws. And this way, the patients aren't surprised when they find they may need to wear elastics after Forsus removal, whether it be for settling or etc., as we determine the final tooth position in their new bite. And just to review, Forsus in our practice we have found creates a really positive atmosphere where patients can succeed and also feel no pressure. They don't get discouraged with themselves when they're forgetting to wear rubber bands because it's not something that they have to think about. It's very easy for them to wear and to get used to, and it's easy for our entire team also now that we've kind of really developed our confidence and our understanding of the appliance. And it's exciting for the patients when they see a comparison, even if it's just of a cephalometric x-ray or facial photos, the differences in their profiles and the bites. It really makes them happy, and it just keeps us all really positive about using the Forsus appliance.
What we can do now, we've been getting some great questions in, and we'll try to get through as many as we can. Thank you, Leanne. And in the past, we've answered some questions, and we can get answers to you. There's a lot of doctors that are asking some great questions, and the same with staff. One that just came through: can you use Forsus with incognito? Yes, you definitely can, and we have found that in the incognito system, you can request the headgear tube, and you can use that in your initial setup. And with that, that would be on the original prescription. Or we have been using some bonded headgear tubes that we place right when the incognito appliance is going to be placed. Now, obviously, you've got your lower arch wire on the lingual. And for the labial, what we have found the most effective way to secure the rod is to put two brackets on the, and keep them low so they're not in sight. Keep them down at the gingiva, and like a Clarity Advanced bracket is nice because you're not going to see it. Put, simply bond the 4 and the 5. Put an arch wire between them, cinch both ends, so all you need is that little span between the two bicuspids, and place your rod there. I like Forsus with incognito because the same thing holds true as kids with Forsus and elastics. With incognito, our patients they don't want to see their braces. I don't think they want to see elastics either. This way you can place a Forsus and it's out of sight. There's some information that we have if you'd like some pictures of that. We can get those to you. And some of the other questions that we are getting, as far as this webinar, it would be housed on the 3M Unitech, the education portion of their website, so you can review that at any time. And let's see, other ones. Do you feel comfortable correcting a full class 2 malocclusion? Yes, we do that quite often. I no longer use a Herbst appliance. I used to use a crown cantilevered Herbst design before we started using Forsus about 10 years ago. Some of these questions too from the doctors you could find on some of the previous webinars that we did. There is information on what about vertical growers, people high angle cases. Yes, you can use Forsus, and you're going to want to place the spring so it's in a more vertical direction. So there's some information on that. The one question I really wish I could answer is, what about Forsus in class 3? And we haven't had much success with that, although I know people that are. It's still kind of a work in progress. Let's see. Again, we're talking about, earlier we talked about different force vectors. A lot of that, that's kind of a long question, or I should say a long answer. And you can get that information from a previous website that we did on vertical control. And let's see. Do you want to grab one of these? Do you commonly run into buccal displacement of the upper first molar? If you see a lot of buccal displacement of the upper first molar, you may want to check your activation, because that's not very common. A question that kind of ties into that. What about second molars? Upper second molars, we usually do not have in place. You can have them if you'd like. We tend to pick them up a little bit later. Lower second molars, again, that's a personal preference if you want to add those. The only thing, and this may be for more of the doctors that are attending, what you need to think about in cases that have a decreased lower face height and have a flat mandibular plane, in those kids you don't want to see molar intrusion. So I really encourage people, stay off of the upper second molars. If the upper first molar intrudes, you then have that second molar as your posterior vertical stop. If you would have put a bracket on the second molar, the first molar intrudes, it may take the second molar up with it due to there being an arch wire. So definitely in kids that have a decreased lower face height, a flat mandibular plane, I really encourage people stay off the second molar, let the first molar intrude. If it does, it'll always rebound, but you can maintain that posterior vertical dimension. Oh, sure.
Yeah, I see one question that I thought was kind of funny as far as whether patients are in pain when we place the appliance. And I will say that we used the Forsus on my younger sister who just completed treatment, and we explained everything to her just like we do any of our other patients. And it was really interesting to be in my position, because the night that she got her Forsus in, she Facebook messaged me to say, oh my gosh, how long do I have to have them? This is so funky and blah, blah, blah. And I told her it would be fine and she'd get used to it, and that she just needed to kind of chew and brush and drink and talk and do the things that you normally do to get used to it. And when I called her the next night and said, okay, so you're still alive, she's like, yeah, what are you talking about? And when I said, your springs, they're not bothering you, she thought they were fine. She had no discomfort, and I felt really confident that, being my sister, she would definitely let me know if she were unhappy about what we were doing. And she didn't complain another time after that, and she was thrilled too with the results of the appliance. So I would feel pretty safe in saying that on average, no, patients aren't going to experience any more discomfort than they would from any form of orthodontic treatment.
The thing I think is valuable is that once we started placing the lower arch wire first, and then placing the springs, when you take those two apart from one another, it was actually the wire that was making kids' teeth sore, not the springs. And we have had patients that we were in the process of correcting with elastics, but they would always say my teeth get so sore wearing these rubber bands. And then when you would put them into Forsus, they wouldn't experience as much discomfort, because what they were doing is they'd wear the rubber bands one day, not the next, but then they maybe wear them a couple days again. And that was that intermittent force that were really making their front teeth sore. Because if you think about how a Forsus is hooked up, when it's really putting the force on the molar, not on upper front teeth when you're hanging class 2 elastics. And particularly, in adults hate that feeling of pulling on their front teeth. So you consider that as well as far as adaptation.
I saw one that just asked how old my sister was. So she was 12 when we began treatment and 14 when we finished, so between 12 and 13 during her Forsus wearing.
She had an interesting open bite as well.
Yeah. I was glad Dr. Albuquerque was able to use the Forsus in her case. I had told my parents that they should be saving for surgery.
There's a question about the first Forsus. Someone had just purchased their first Forsus kit, and their sizes all the way from 25 to 35. We use a lot of the smaller sizes. We start with 22, 25. We sometimes will make it up to a 29. I just placed a 29 this morning after we had activated a 25. And actually it was an incognito patient that we had just placed that 29. The 35 I don't think that I have used before, although sometimes we will kind of modify the size of those. So usually if you go behind the first buys, you're going to use smaller rods than if you're going behind the cuspids. One thing to keep in mind that's been, I think, a big difference for us is when we first started to use the appliance. If there was a broken bracket, anything was broken, we felt like we had to take the patient completely apart, put them back together, and we lost time. Kind of keep in mind that tip that Leanne gave you, just crimping a hook onto that arch wire and keep going. You can always pick up brackets after you get the class 2 correction. How far into treatment are we usually placing Forsus? Most of our patients, it's about the 10-month period, I would think. Don't you think, Leanne? Because you've got to work into a rigid wire. Now, one of the questions was, do you ever use a 19 by 25 stainless? Yes, you can. You can use stainless in the lower. You can use a beta. We used to always use stainless with our Victory Series bracket. We use a smart clip bracket now. We like the beta because sometimes when we're placing our Forsus, our mandibular occlusal plane might not be completely level. Forsus is a great way to intrude lower incisors, so sometimes we need a wire that we can manipulate easier, and that beta will do it. The stainless is just too stiff to be trying to place some bite opening curve into it, but you can use the stainless. The only thing I don't recommend is night tie. It's just not stiff enough. We're in an 022 slot. Even a 19 by 25 night tie just doesn't have enough stiffness between the brackets. What happens is the rod will start to depress the bicuspids. So you're not going to see an AP correction. You're going to see a deepening of the curve of speed. Most patients, if you're going to standard class 2 correction, will have their Forsus in for about 6 months because there's some questions about treatment time. Now, non-growing patients, it may be a little bit longer, or those ones that are a full step class 2, those may be 9. Probably the longest anyone's had their Forsus in has been 11 months, and it was someone that we were completely shifting a midline and making space for blocked out teeth. So that takes a little bit longer because, one, you have to distalize and then you kind of hold it there, like using it like a headgear as you're pulling against it. But for standard class 2, about 6 months. Now, the one question that's talking about a CRCO slide, if you're afraid you have that discrepancy, leave that appliance in. What we'll do is we'll get them to the final position and then hold them there. Don't take it out as soon as I'm in a class 1 or my overjet's gone, I'm taking it out. Leave it in there passively until you're sure that you're not positioning. A lot of the things you already know with class 2 elastics applies to Forsus. it's kind of like, there's some of those patients that kind of, you manipulate the mandible and you see there's a CRCO slide, and even though they swear they're class 1, they're really class 2, and you're like, nope, you have to keep wearing your elastics. Those same type of principles apply with the Forsus. Is the Forsus autoclavable? I don't know if it is. We don't reuse them, so I can't answer that one. So no, we don't use them. And as far as the cost of the appliance, how do we factor that in into treatment fees? Yes, there is some appliance cost, but the thing is, you gain so much of that in efficiency, you make it up in time. So as far as when you're figuring out the expense of the appliance, you save it really in time and lack of frustration. And, those positive interactions you have with patients really grow your practice. What you may consider is, we base fees on really the level of difficulty. So we don't say, okay, here's what braces would be, here's what your Forsus is going to be. We package it all together, and this is everything we would need to use to correct your malocclusion, get you to that smile you want, get you to the end result. So no, we don't go ahead and and charge extra for that. Unfortunately, we are out of time. We've got some great questions we didn't get to, so we apologize for that. And let me give you the contact email address. That way, if some of these you want to email us directly, we can get you those answers. Or some of them would be best answered even with a picture, if I could show you, or if Leanne could show you. The contact information would be lectureinfo@elvitro.com. Or if you want to even go on to the 3M website, again, there's other Forsus, and there's also this webinar as well. So we appreciate your time, and we hope you found it interesting and worthwhile. And
thank you very much. I hope I was understandable and not too fast talking. Dr. Alvitro definitely is much more the professional with this.
Thank you, and have a great weekend.